Hi everyone, welcome to my channel. My name is Judith Olsen-Sapio, and today we are going to have a review on calcium channel blockers as part of our review on the cardiovascular pharmacology. These are a class of drugs that are widely used, especially in cardiovascular conditions, like you can have this preempted to you here. In this review, we are going to look at the mechanism of action, clinical indications, the adverse effects, contraindications, drug interactions, and then we will also have a look at the nursing considerations. Starting off with the mechanisms of action. How do calcium channel blockers work? First of all, these drugs can also be called calcium entry blockers or calcium channel antagonists. And like their name sounds, they are going to block the entry of calcium, and resultantly, they are going to reduce the amount of calcium in the cell. What are the targets of action of calcium channel blockers? So the targets would be the vessels, and then it will also be the heart. Okay, the vessels and the heart. Calcium channel blockers work to reduce the amount of intracellular calcium such that we can reduce activity in these targets. We can reduce the contraction of the smooth muscles of the vessels or the contraction of the myocardium, or even the conduction of impulses from the sinoatrial node through to the atrioventricular node and then onto the heart. So if that's the case, how does that then come about? And I'm going to discuss this into two parts. What happens when calcium channel blockers are working on vessels, and what happens when they're working on the heart? Because while they are going to reduce the amount of calcium, how they achieve that is slightly different. So let's say we are working on the vessels. What is going to happen? Now, the calcium channel blockers, of course, like the name says, we are going to have some channels in here through which ions enter, and these channels are described as L voltage gated channels. Okay, these are channels that are found on smooth muscles and then also on the heart. So the calcium channel blockers are going to plug off these channels. They're going to close off these channels so that we block the entry of calcium into the cell, and therefore we are going to reduce the intracellular calcium. And what is going to happen? On the vessel, this vessel is going to relax. And then what happens in the heart? Okay, now in the heart, the calcium channel blockers usually also still work by reducing the amount of calcium entering in here, but in the heart or in the muscles themselves, we do have stores of calcium. So let's say we have the sarcoplasmic reticulum, and this is rich in calcium. Okay, we have calcium in this. So in myocardial muscle, usually when calcium enters, let's say when we have an entry of calcium into the cell, the increased intracellular calcium is going to trigger the sarcoplasmic reticulum to also release calcium. We call that a calcium-induced calcium release. Calcium-induced calcium release. So through the calcium channels, the L voltage gated channels, calcium is going to enter the cell, and then the increase in intracellular calcium is going to trigger release of calcium from storage sites in the sarcoplasmic reticulum. And of course, that is also going to result in an increased calcium concentration, which increases the force of contraction and the heart rate. Now, when we block these channels, okay, when you block these channels, of course, again, we are going to plug them. And when we plug them, we will have a reduction in calcium ion concentration inside the cell. Now, because we are having that reduction, we will also have a reduction in the release of calcium from the sarcoplasmic reticulum. So at the end of the day, we are basically going to have a reduction in intracellular concentration of calcium, and that is going to bring about a reduction in force of contraction, a reduction in heart rate. So in summary, how then do calcium channel blockers work? Calcium channel blockers are going to block the entry, block entry of calcium into cells, and that is going to reduce intracellular calcium. And yet we know that calcium is responsible for muscle contraction. So if we are having a reduction in intracellular contraction, we are going to get muscle relaxation. Okay, we will end up with a muscle relaxation. Now, depending on the kind of muscle, if it is vascular smooth muscle, we will end up with a vasodilation because we are going to relax those smooth muscles of the vessels and then they are going to dilate. And then if it is in the heart, we are going to end up with a reduced force of contraction, a reduced conduction velocity, and of course a reduced heart rate. So we can then say calcium channel blockers dilate vascular smooth muscles, reduce the force of contraction, and then also reduce the conduction velocity by blocking the sinoatrial node and the atrioventricular node, and then ultimately reducing the heart rate. So what are the examples of these calcium channel blockers? We have two types of calcium channel blockers. The first type are the dihydropyridines. These are drugs whose names end in the dipines. So think about such drugs like amlodipine, felodipine, nicardipine, isradipine, nifedipine, etc. Those are the dipines. Now, the dipines preferentially are going to work on vascular smooth muscles. The dipines work on vascular smooth muscles, and it's important we understand that distinction because it explains a lot the effects that are produced by the dipines vis-a-vis the effects that are produced by the non-dipines. So the dipines selectively act on blood vessels to cause vasodilation because they're going to reduce intracellular calcium and relax those vessels, so the vessels are going to dilate. So the dipines do that. They are preferentially vasodilators. And then the second class of drugs are the non-dihydropyridines or the non-dipines. And these are further subclassified into the benzothiazepines like diltiazem or cardizem. And then we have diphenyl alkyl amines like verapamil. Unlike the dipines, the non-dipines are going to act on both the vessel and then the heart. What does that mean? They are both vasodilators and then they also act to reduce force of contraction and they act to reduce a heart rate. This distinction is very important. In fact, it would explain why the dipines may be used, for example, in hypertension, maybe in angina pectoris, but then they will not be used in dysrhythmias because they don't do anything to the SA node and then the AV node, while the non-dipines might be used in conditions for which we need to either slow down the rate of the heart itself or the force of contraction. That distinction is necessary, and I will emphasize it that the dipines are vasodilators, while the non-dipines are both vasodilators and then also they produce negative effects on the heart. Now, once we have understood those facts about these calcium channel blockers, what clinical conditions may we use the calcium channel blockers? The first clinical indication is going to be angina pectoris. So angina pectoris is an ischemic chest pain or chest pain that is produced by myocardial ischemia because less blood is flowing to the heart and the heart muscle are receiving inadequate blood, inadequate oxygen. So the patient feels a kind of a heavy crushing type of pain that radiates to the left part of the body. In angina, we are usually dealing with a problem of supply and demand. Either the heart is demanding a lot or the supply is little. So when we use anti-angina medications, we want to restore that balance between supply and demand. And calcium channel blockers help with that. How? Calcium channel blockers are going to dilate the vessels. And if they dilate the vessels, then they're going to improve on the blood that is flowing to the myocardium. And for that reason, we can use calcium channel blockers in both stable and unstable angina, together with the other anti-angina medications like beta blockers or the nitrates. And then calcium channel blockers would be the anti-angina drug of choice in Prince Metal's angina or in vasospastic angina. Vasospastic angina is angina that is caused because the vessels are undergoing vasospasms, and that also reduces the amount of blood that is flowing to the heart. So the calcium channel blockers are going to relax the heart so that we don't have those spasms. The clinical indication is in hypertension. In hypertension, we have usually either an increase in cardiac output or an increase in resistance within the vessels, usually because the vessels are going to be constricted. So the calcium channel blockers are going to relax and dilate those vessels so that blood flows with less pressure. So in this, we can use the deepins. We can even use the non-deepins. And then in dysrhythmias, calcium channel blockers, especially the non-deepins, diltiazem and verapamil, can be used to manage atrial flutter, can be used to manage atrial fibrillation, and of course can also be used in supraventricular tachycardia. In fact, before adenosine became the drug of choice for SVT, for supraventricular tachycardia, diltiazem was being used. Another indication is in Raynaud's disease. In this disease, we have constriction of peripheral blood vessels, especially on the extremities, which usually cut off sufficient blood supply to those areas. So the patient, especially in extreme conditions like when they are exercising and therefore the need for oxygen increases, or when the climate is very cold and vessels are quite constricted, those clients are going to feel pain in those extremities. So calcium channel blockers help to dilate those vessels so more blood can flow to the extremities. Another indication is in migraine headache because during migraine headache, it's believed that the vessels are also undergoing spasms and the calcium channel blockers are going to relax those vessels. We can use calcium channel blockers for preterm labor because those drugs are as well going to relax the uterine smooth muscle. Then another indication is in cerebral artery spasms, especially if, for example, a client has had a cerebral hemorrhage or aneurysm, a ruptured aneurysm, and they're bleeding in the brain. The vessels usually also do undergo spasms, and calcium channel blockers are going to relieve those spasms. So generally, the choice of a particular calcium channel blocker for a particular condition is going to depend on whether you want it to act on the vessels or you want it to act on the heart. If you preferentially want vasoactivity, then you're going to choose the deepins. And then if you want an activity on the heart or both, then you're going to choose the non-dihydropyridines. Let's look at the adverse effects of calcium channel blockers. And really, for us to be able to figure out what the side effects or the adverse effects for calcium channel blockers are, you need to reflect on the way they work. So because they are going to vasodilate and also reduce the force of contraction and heart rate, they are really going to reduce the blood pressure. So hypotension is a common side effect with calcium channel blockers. And then we also do have tachycardia and palpitation. This is seen mainly for the deepins, which are selective for blood vessels. You see, when the deepins are relaxing the blood vessels, okay, when they relax these blood vessels, blood is going to flow with less pressure. And then as it is circulating, the baroreceptors in there are going to pick the information of a reduction in blood pressure. And what does that do? That stimulates the sympathetic nervous system to release norepinephrine. And then norepinephrine is again going to cause a counter effect. And what's that counter effect? An increase in heart rate and probably an increase in force of contraction. So you see that we initially ended up with a hypotension, but because of the response to that hypotension, we again having a tachycardia and palpitations. Then calcium channel blockers will also slow down the heart rate, especially the non-deepins, verapamil and diltiazem. Then because of their vasodilating effects, we are as well going to see flushing. Patients will complain about headache and of course dizziness. They block conduction from the sinoatrial nodes to the atrioventricular nodes. These drugs can block the heart or can cause an atrioventricular block. Then their vasodilating effect is also going to bring about peripheral edema, and patients may also complain about a dyspnea and or even a shortness of breath. Once we know about those, what would be our contraindications? The first contraindication is in heart failure. In heart failure, the heart is not producing adequate cardiac output to meet the body's metabolic demands. And it can be a function of two things. Either we are having the left ventricle not contracting strong enough to push or to eject that fraction that goes out into the body, or we are not having the relaxation of the ventricles good enough to receive the blood, which blood eventually will be ejected. Now, because we have seen that calcium channel blockers can dilate vessels and calcium channel blockers can cause negative effects on the heart, negative chronotropic, dromotropic, and even inotropic effects, then we don't want to give calcium channel blockers to a heart which is already failing, because we are just going to aggravate the situation. We are going to make the heart failure worse. In fact, calcium channel blockers can even cause heart failure. We also don't want to give calcium channel blockers in clients who have experienced an acute myocardial infarction, okay? Because also most commonly these clients are going to have features of heart failure, and providing adequate cardiac output for tissue perfusion is going to be affected. We've already seen that these drugs cause AV block. We don't want to give it to a client who has experienced an AV block. Don't give calcium channel blockers to clients who have baseline hypotension, because these drugs are going to further reduce the blood pressure. If we take our baseline pulse rate and we are reading in the ranges below 60 beats per minute, then we don't want to give calcium channel blockers, because they're further going to reduce the heart rate. It's also important for us to look at common drug-to-drug interactions that occur when patients or our clients are prescribed calcium channel blockers. For anyone who is sitting for the NCLEX, grapefruit juice should not be given concurrently with calcium channel blockers. Grapefruit juice interacts with calcium channel blockers in the sense that the grapefruit juice is going to inhibit the metabolism of calcium channel blockers. So what happens? We are going to have the CCB stay in the body for much longer, and of course then the adverse effects and toxic effects of the CCBs would be more pronounced. For anyone who is sitting for their NCLEX, when you see grapefruit juice and they're asking you, and I mean the question is talking about calcium channel blockers, those two cannot be given together. Also, apart from calcium channel blockers, just for you to get that information, grapefruit juice should as well not be given with statins, and grapefruit juice should not be given with cyclosporine. Every time we reduce metabolism of something, you're delaying its clearance from the body. So it stays in the body much longer, and then we can get adverse effects or toxic effects of those. So this would be an example of a drug-food interaction. CCBs interact with beta blockers. How? CCBs remember, CCBs cause vasodilation. Some beta blockers are also vasodilators. CCBs are as well going to cause a reduction in force of contraction and heart rate. Beta blockers also cause reduction in force of contraction, reduction in heart rate, reduction in conduction velocity. So what are we going to end up with? A pronounced depression of the heart. Okay? That is what you're going to get. A pronounced bradycardia, for example, a pronounced hypotension. So we don't want to have that. You can call it pronounced or additive because you're adding the effects of these drugs and adding the effects of CCBs, and then you come up with an addition. Then calcium channel blockers also interact with digoxin. How? Remember, digoxin is going to produce a negative chronotropic effect. Digoxin is going to produce a negative dromotropic effect, reduces conduction velocity. So we can also end up with an additive and pronounced bradycardia when digoxin is given together with calcium channel blocker. Amiodarone is an antiarrhythmic drug that is given usually for a number of ventricular dysrhythmias. Let's say when we have a ventricular tachycardia. Now, amiodarone also does interact with calcium channel blockers. Okay, so the interaction between amiodarone and calcium channel blockers is also that of a reduction in metabolism. So what happens? Amiodarone actually reduces the metabolism of calcium channel blockers. So once again, the effects of calcium channel blockers are going to be more pronounced. Then we have this, the azole antifungals, macrolides, and protease inhibitors. Going to inhibit metabolism of calcium channel blockers. Statins, we shall say calcium channel blockers are going to inhibit statin metabolism. Statins are drugs that are given in hyperlipidemic states. They work by reducing the synthesis or by inhibiting the synthesis of cholesterol. They are very excellent in lowering low density lipoproteins. However, they come with downsides. Statins are known to be toxic to muscles. They cause what is called a rhabdomyolysis or muscle breakdown. They also are very toxic to the liver, so they do cause hepatotoxicity. So if calcium channel blockers are going to decrease statin metabolism, you are going to have a raised level of statins in blood, and then clients could end up with those bad adverse effects. Cyclosporine is an immune modulator, which is usually given in immune condition. Interaction between cyclosporine and calcium channel blockers is two-way. Again, it's to do with metabolism. Calcium channel blockers inhibit metabolism of cyclosporine, and cyclosporine also inhibits the metabolism of calcium channel blockers. The adverse effects of both are going to be pronounced. Let's look at some of the considerations that we have to put in mind when our clients have been prescribed calcium channel blockers, and our role as nurses is to administer those drugs and also to monitor the effects of the drugs. Of course, the first thing that we want to do are to take baseline vitals. Baseline vitals help to give you parameters that you will use to compare with your subsequent measures. So we can take baseline blood pressure and pulse rate, bearing in mind that these drugs are going to reduce blood pressure and also reduce heart rate. So before we give calcium channel blockers, we want to ensure that our blood pressure is at least above 90/60 millimeters of mercury, and also our pulse rate is at least 60 beats per minute. Once we have given, then we have to routinely or to periodically monitor still, because those vitals are going to come down. When the blood pressure is less than 90/60 millimeters of mercury, you withhold the dose that you are preparing to administer. You notify your prescriber or your healthcare provider. You let them know you have held it and let them know the reason you have held it. The same thing with the pulse rate. When the pulse rate is reading less than 60 beats per minute, we are also going to hold that dose and then let the prescriber know. The reason is we don't want to lower those parameters further, because if we do that, we're going to end up with a very low cardiac output and tissues are going to suffer. So for the NCLEX and for nurses, we always want to keep our patients safe. We want to reduce the risk potential. So as taking these parameters in anticipation of something that might happen will help us to prevent that thing from happening. Weigh these patients daily. Why do we want to weigh the patients daily? Remember, because of the vasodilation, they may hold fluids. They may get edema because fluid moves out of the vessels. This is the absolute way for us to determine fluid status in the body, because weight takes into account even the insensible fluid losses, like the one that I'm losing while I talk. Ensure that you weigh them at the same time. You weigh them using the same scale. You weigh them while they're in the same cloth, okay? And preferably, we weigh them when they've woken up in the morning, before they've taken the breakfast, and when they've eased themselves. Monitor for the adverse effects of edema and shortness of breath. And if this, especially if shortness of breath occurs, we need to report to the healthcare provider. Another thing we also want to have in mind is that we don't want to abruptly withdraw these medications. You don't just suddenly stop taking the medications, because when we do that, we are instead going to end up again with a rebound hypertension. So even when we are teaching our clients, we want to teach them not to abruptly withdraw. We want to taper the doses and then we remove it gradually. Then, because these medications are going to cause a reduction in blood pressure, orthostatic hypotension is going to occur. Okay, that's hypotension that occurs when we change a position from a lower one to an upright one. So we want to ensure that clients move and change their positions slowly, gradually, and cautiously. Even when we are teaching them, you emphasize that if they suddenly get up, we're not going to have adequate time for the hemodynamics to adjust. So the clients may easily get severely hypotensive and then they could fall. We don't want that to happen. Now, calcium channel blockers also do cause constipation. I forgot to add it here. Verapamil is known to cause constipation. So for that reason, we want to teach the patients to increase their fluid intake, but also to increase fiber in their diet to help with the constipation. Of course, with fluids, we usually say at least 2,000 ml per day or 2 liters in 24 hours. Okay. Report any palpitations, pronounced dizziness and dyspnea or shortness of breath to the healthcare provider, and also teach the patient to report that, to notify you or the healthcare provider in case they are experiencing this. And then when we are giving these calcium channel blockers intravenously, we want to monitor these clients closely, because intravenous administration is a sure way of getting the drug directly into the blood, and therefore the effects are usually very fast and sometimes more pronounced. To prevent the adverse effects that might occur very fast, one, we want to give these medications using an infusion pump. An infusion pump helps us to regulate the doses accurately so that we don't give beyond or we don't give below. Also, we want to attach them to a monitor that helps us to see their parameters, okay? So that once we notice that there is either a reduction or a fluctuation in the parameters, we are able to intervene appropriately. Teach the patients to avoid grapefruit juice when they're taking calcium channel blockers. This is a very common question on the NCLEX. And that brings us to the end of our review on calcium channel blockers. I hope that it has been helpful for you. I would like to thank all of you who come in and watch these videos, and also those who go ahead to subscribe. For those who have not subscribed to this channel, subscribe to the channel so that every time I post something, you will be able to get it. Also, turn on your notification button so that you are made aware in case a new upload has been added. Also, like and please comment. Please suggest which areas you would want me to talk about so that I can make a recording about it. Otherwise, I thank you so much and I wish you all the best.